and we had a very good Indo-Israel spine meet, and that actually trickled beginning of a spine surgery or spine super specialty in Pune. So, but initial teething problems as usual were everywhere. Most of our orthopedics colleagues, they thought that spine is nothing. They were referring it to neurosurgeons, and we had a lot of time in convincing our colleagues. It was difficult initially that spine needs orthopedic and neurosurgical training. And as you can know, that American Academy of Neurosurgeons has given a white paper saying that it is an emerging specialty and you have to have training in orthopedic surgery as well as neurosurgery. So when American Academy of Neurosurgery says that, I think it has some credibility. So after this, I had an opportunity to go further in spinal surgery. My professor in Israel had referred me to the Center for Spinal Surgery in New York. As yesterday you have listened, Dr. Boachi was the chief there at the Center of Spine Special Surgery in New York. But because my visa was refused to US as I was thought to be a potential immigrant, I got an opportunity to go to Japan. Actually the fellowship which was given to me was actually for an American surgeon, and that changed and enhanced my skills further. In 2001, I was given a spinal injury center fellowship by American Academy, and at that time I had opportunity to attend Japanese Orthopedic Association Congress, annual Congress, something like our IOA, and that time they were talking of new challenges for orthopedic advances in 21st century. And Professor Takemitsu, as you see in this picture, he was my guide at Spinal Injury Center, and he was also Asia Pacific Orthopedic Association president that time, and he really helped me day to day. This Spinal Injury Center is an individual hospital spread over 200 square kilometers, and it had equipped with all the rehabilitation things along with helipads. Most important besides spine surgery, what I learned, number one, very important is the punctuality. I can quote an example that I landed in Japan on Saturday and it was snowing everywhere. It was my first experience of snow. So I was locked up, let us say locked up in my flat which was allotted to me in the hospital, and professor told I will come and take you to the hospital ground at 12 noon. And I was just waiting at 11:45. I was just wondering when professor is going to come, because I didn't know their language also, Japanese language, I didn't know that time. And suddenly I happened to peep through my door, and I found the professor was standing outside. Then I said him, sorry, open the door. And then he said, no, wait, I have given you time of 12 noon and there are still 5 minutes. I will come after 5 minutes. So they are so much punctual. In Japan, even if you travel anywhere, if it is said that this station will arrive at this particular hour of a day, the doors will open and you just get out and you are in that station. Trains and everything is never late. So very important thing to learn in life is to have punctuality in life. Second important thing what I learned is evidence-based medicine. Professor Takemitsu was actually a student of Singaporean surgeons who developed anterior spinal fusions or anterolateral debridement for tuberculosis spine. And my colleague, when I was doing MS Ortho, Dr. Gautam is here. His thesis was ASF with ALD for tuberculosis spine. So when I talked to him our Indian experience, he just nodded and didn't say anything to me. Next day before our morning meeting, he came with 2 big trolleys full of case papers. And then he told, Dr. Bhave, you were talking of ALD with ASF. I was a student of Hodgkin and Stock in Hong Kong, and I learned from them primarily this procedure. But these are our case paper records right from 1993. This was the initial procedure we learned, 95, modified this, 97 like that, and in 2001. This is how we are doing, and this is the evidence of the patient and long-term follow-up. This was something unknown to me, because in our country we are used to people saying, in my experience, I do this and everything works. No, even a person like Takemitsu never said this, and he documented everything, and that is what we are in 2001. That was his last sentence, and I was convinced that using loose words or loose sentences will not be do anymore in the future. Then I had good opportunity to get interacted with Professor Kiyoshi Kaneda. Actually, he is famous for his anterior spinal instrumentation. Whatever plates we are using spine anteriorly, he is the pioneer person, Kiyoshi Kaneda. And he had visited our hospital that time, and I had good experience to learn from him his philosophy of anterior spinal instrumentation and anterior spinal surgery. And after that, I had a chance to become a JOA fellow in 2008, and that also changed. In the meantime, I was selected by Hokkaido University, and they awarded me Hokkaido University scholarship in 2007. Main turning again point was introduction with Professor Kiyoshi Abumi. He is the originator of cervical pedicular screw, and he is very polite and decent surgeon. So with him, he also introduced to me Dr. Boachi. Actually, I had missed him long back because I was refused American visa, and that was again an interesting point for me in life. So whatever I had missed few years back, the Boachi himself had come and met me at Hokkaido University and showed his interesting techniques of scoliosis correction. And then in Pune, we had already started doing lot of complicated cases. This is an example of cervical dislocation. This is another example of severe radiculopathy, upper limb weakness, treated by cervical disc replacement. You can see the post-operative pictures. Complex scoliosis correction, degenerative scoliosis. These are just few representative slides what we are doing in spine unit in Pune. Then came my opportunity to learn in Korea. I went to Seoul, that is a Wuridul Spine Hospital. This is a Professor Sang-Go Lee, who is a world famous neurosurgeon, and he is pioneer of minimally invasive spine surgery. I had good opportunity to work with him, and he has 25-storied spine center that time, and now you can have many more such Wuridul hospitals all over the world. So he has now chains of hospitals, but I was one of his first international student on his routine international fellowship. What was important is individual training on models. Before you are actually doing hands-on something, then burying on a triangulation method, that is, you are looking at the screen and trying to put the endoscope inside. And I learned endoscopic discectomy fully under local anesthesia from him. Actually, the hands-on every Sunday was really, I was craving for it. Because what they used to do is, they had supplied us with 12 eggs. As you know, आपल्याला मराठीमध्ये शहामृग माहिती आहे, त्याची अंडी एवढी मोठी मोठी असतात. So tashi there was some other animal in Korea, and they used to provide us 12 eggs every Sunday. And like a patient, that egg was tied to the operating table. We were given operating microscope, and various designs were drawn with a pen on the eggs, and with a burr. We were giving burr, and these designs आम्हाला ते कोरून काढायला सांगायचे without breaking the egg, and that is how you develop the technique and safe handling. Assuming it to be a brain, assuming it to be a cervical cord, you should not damage it. So prevention of dural leak, dural injury. So that is how hands-on training was very important for us. Next step is developing the finger activity. So for that, they used to tie our wrists and taught us operating with fingers. That is also very important thing. All of the young surgeons should know it and try it. It is very worth doing it, and that is how they gave us a lot of arteries and veins for anastomosis. And these are the two very important techniques what I could pick up from them, and endoscopic techniques from them. And when I came back to Pune, we started using this. This is an example. 25-year son male patient. You can see prolapsed disc with left lower limb weakness. As per the principles of endoscopic, you do the discograph, confirm on table that patient has the same pathology, and using the principles of endoscopic transforaminal endoscopic discectomy, you can see confirmation by discogram. Next is fragmentectomy. Remove the fragment of the disc which is hurting the nerve root, and then close the annulus with thermoannuloplasty. So these are the basic steps in the transforaminal endoscopy. You can have big fragment like this to removed on table, and you can see you can remove as big chunks of prolapsed disc with endoscope. So what we used to do with open surgery, you are able to do with endoscopic spinal surgery. So you can have happy patient on table because all these surgeries are done under local anesthesia, and as soon as you remove the fragment, patient says my pain is gone, and that is a good end point of the surgery. Another example, same scope we are using by interlaminar ways. This is an example, prolapsed L5S1, and you can remove as big chunks of as big as 5 centimeters, and this is a single stitch surgery. You can put a stitch or you may not put a stitch. So next is experience in USA. I was fortunate that Professor Charles Dindray, who was then president of American Neurosurgical Society, he is actually originator of artificial nucleus replacement. He was one of my teachers, and he was after me to pursue spine further, and that is how I could pursue my career with the good wishes of my mentors in different ways. Way back, coming back to life and philosophy, I was always influenced by Swami Vivekananda, and he always told, get up, put your shoulder to a wheel. If you have come in this world, leave some mark behind. Also, my Israeli professor advised me, go back to India, develop your own instrumentation which will suit your population and their requirement, and also cost, because I know that India cannot afford all costly equipment of surgical treatment. And at the same time, WHO had published a report that by 2025 or 2025, 40% of Indian population would be above the age of 60 years, and most of them are osteopenic or osteoporotic. And also I read one report from US, and they said that problem of osteoporotic spine fractures is so immense, and even in developed countries like United States, only 20% are diagnosed and rest are undiagnosed. So it is a large chunk. So I came, every time I came back from foreign countries, instead of getting souvenirs, I got some small surgical equipment with me. So when I came back from Korea in 2003, I had got multiple vertebroplasty needles which I tried initially in our patients for osteoporotic spinal fractures. But I had my own share of complications because this needle, I faced lot of breakages and had lot of problems. So, and the cost of these devices was more than $3,000 US. So it was not affordable for a common Indian person. So I tried to have a device which will be effective in cost, function and utility, and which will take over all my complications which had occurred during my learning curve. Also for the vertebroplasty, because our theatre conditions are different, that time CMW 1 cement was only available and no vertebroplastic cements were available. So we modified the procedure of vertebroplasty. We changed and devised a new device which has got multiple channels. So even if one hole blocks, you can have a 360 degrees filling of the cavity, because as you say, fracture tibia transverse fracture is a 2-dimensional fracture, but vertebral fractures is always 3-dimensional. So you have to have a uniform filling of the cavity. That was the principle of my device, and it should fit any syringe available in India, right from district to topmost apex hospital like AIIMS in India, where my device could be used. And the cost of this device is less, and the syringes cost you 2 to 3 rupees. So the patent office, Indian government, I got this patent for my vertebroplasty device. And it is the first Indian instrument after we have come under the patent law. So this is another thing what we could do, something indigenous for our patients. And the peculiarity of this device is it has got a unique locking system. So it does not unlock during surgery. Even if one hole is blocked, you can use other channels. So continue with the same device. Don't increase the charges to the patient. Then it fits any syringe available in India. And as you see in this clip, it is uniformly filling the osteoporotic fracture cavity. Next in line, because the vertebroplasty had some limitations that you cannot use it in burst fractures or complicated situation, I had good opportunity to develop a new non-fusion device for this osteoporotic fracture, and it is termed as vesselplasty. Professor Darwano from Indonesia I met in 2002. And then he involved me in his research and I had really a good opportunity to learn from a basic idea what we wanted to have a closed system where cement won't leak and cause injury to the spinal cord. So from development of initial idea, we developed a prototype, and whatever shortcomings were there, we developed 3 generations of this implant. Then I had an opportunity to do animal experiments in about this implant. Then we did biomedical experimentation in Beijing laboratory and San Francisco laboratories, and then finally got US FDA and EC markings. And final implant is a 3rd generation vesselplasty implant, and the implant, the initial idea what came to us in 2002 and 2003. In 2014, I am able to use in my own spine unit. So it is something different medical curriculum I had. Whatever implants we are using today are developed by some other people, but developing your own implant and using it it is something rare occasion in your once surgeon's life, and that I had really an opportunity to learn right from beginning to the final outcome. And this implant is already used in Europe. 2,400 implantations have already been done in US and Europe. And in 2014 in India we have started using this implant. The design, it is a PET non-stretchable container which prevents the cement leakage. It has got 100 micron pores through which the cement can come out and interdigitate with the bone marrow or vertebral marrow, and it can expand and gain height in a collapsed vertebral fracture. So this is how it works. The pressure inbuilt will uplift the end plates and gain height. Interdigitation will allow a stability, and that is how you will have good kyphoplasty or non-fusion technology. And everything is done under local anesthesia, under C-arm control. This is one example. 70 years old, 2 months back, she is collapsing. You can see these are the C-arm pictures. Everything is done under local anesthesia. Track is made, implant inserted, and you are injecting the cement. You can see gain in height. The post-operative 8 weeks dynamic X-ray, you can see no collapse, and this is a clinical picture. Patient is walking and you have to find the scar where she has. So we have come from basic vertebroplasty device to vesselplasty. That is something new to learn. This was all about my learning so far. From 1998 to 2010. I had visited spine units of more than 10 countries all over the world. Different units had their different peculiarities and specific surgeries which were specific to that particular unit. So it was really a challenging thing, and also most of the learning was in non-English speaking countries. So I learned many languages besides German, Hebrew, Japanese and Korean, and my 3 languages Marathi, English and Hindi and Sanskrit are already there. So what I found is whatever textbooks what we are learning today, they are all very, very expensive, and none of the textbook is complete giving you an idea of what is coming or what is there in a field, in a particular field. So I learned this procedure from individual people who had devised these particular procedures with their philosophy, and finally I thought this would be a better idea to put it in a book and come out with a book which should be low cost and affordable to our residents. Because when we were residents, we really could not afford buying textbooks, and we had to make Xerox copies and learn from them when we appeared for our MS exams. So this book was my second book. It took 5 years for me to complete, but it is become very, very popular. It is extensively reviewed in JBJ's British, European Spine Journal, European Orthopedic Journal and International Orthopedics. And recently it is translated in Spanish language, and as you heard yesterday, Dr. Boachi from Center for Special Surgery in New York, he has got forward for this book, both English and Spanish editions. We have come out with another new book in 2015 January, and as I learned last month in a Frankfurt International Book Fair, this has got largest inquiries for this book, ahead of other publications in the world like Lippincott Williams and other things. So this is our latest publication, what we have, and it has got all the common surgeries are being done in our country, and it is with DVD-ROM also. So during my various trainings in various countries, what I learned is avoid impatience. because it can cause wise people to do foolish things. This is a famous statement. Avoid unwanted surgeries, avoid unethical work practices and financial relationships. As William Mayo of Mayo Clinic has told, the best interest of the patient is the only interest to be considered. What I learned is, do not harm the patient. Before starting any procedure, you work on cadavers, work on models, repeat the steps in mind, develop your psychomotor skills, and then try and do your surgery. Get training on gadgets, because fool with a tool is still a fool, and hence you have to be educated, get trained, and then start doing the new surgery. Another important thing is, in India we have chalta hai attitude, but never have a chalta hai attitude. No, don't compromise in your surgical steps so that you don't have any fallacies and you will have good results at the end. As Confucius had said, choose the job you love passionately and you will never have to work for another day. So what I learned is, क्या फर्क पड़ता है हमारे पास कितने लाख है, कितने करोड़ है, कितने घर है, कितने गाड़ियां हैं, खाना तो बस 2 ही रोटी है, जीना तो बस एक ही जिंदगी है। फर्क इस बात का पड़ता है कितने पल हम खुशी से बिताए और कितने लोग हमारे वजह से खुशी हुए। So what I learned is, it is not important that you do 100 surgeries or 1000 surgeries, but how many of them were done to perfection. That is very, very important. And what is important is how many patients were really benefited because of your surgery. So currently I am working as a spine surgeon in Dinanath Mangeshkar Super Speciality Hospital, Pune, which is a really new super specialty hospital built in city of Pune. Journey so far in various fields was like this. I do not know what God has decided for me in future. I conclude saying thanks to my parents, because nowadays children and students question everything. When we grew, we did what our parents told us and never questioned them, because we believed that whatever they told us was the right thing. I thank them for telling me right things in my life. Guru and teachers, I think all first line are on all my gurus, so I don't take name by a name, but all gurus, parents and teachers are always being guidance force for me. From my first teacher at MS Orthopedics, Dr. Isbud, I learned from everyone I came across. I thank my wife and son for providing work-home balance in life, because my life so far has always been heavily unbalanced, because I used to stay in India for 6 or 8 months and travel abroad learning new things in spine all the remaining part of the year. I thank you all, colleagues, friends and POS members who have made me POS president in 2010 and 11, and that is how I am here today. I thank you everyone. Long live POS. Jai Hind.
Oration.
Thank you, Bhave'S sir, for such an excellent talk. It was really wonderful to hear this. It was really motivating talk. When we decided, sir only decided a topic of his oration. It's really good. I think it's an very much provocative, going to be the new additional surgeons in our society. With this, I request Dr. President of Pune, Dr. J.M. Talesara, to please felicitate Dr. Arvind Bhave'S. Thank you very much, sir, once again for a wonderful talk. With this, now we'll break for a lunch. But after lunch, before lunch, Dr. Bhave'S sir want to make one announcement